All right, I think I will get started here. If anybody cannot hear me, please put something in the chat so that we can fix that. My name is Dr. Lindsay Van Dyke. I'm a board certified endocrinologist in the greater DFW Metroplex in Mansfield, Texas. And I've been providing radiofrequency ablation of thyroid nodules since about 2021. And I wanted to offer an opportunity to kind of give an overview about this procedure, why it's useful, so people can kind of make some decisions about whether it makes sense for them. With us today is Jennifer Holkheim, who runs, Save the Thyroid, and has been an early and passionate advocate for RFA for patients. Let me share my screen, and we will get to it. And of course, post questions in the chat as we go. I'll kind of keep an eye on that and answer when things come up. So non-surgical treatment for thyroid nodules is a very big deal. I mean, that represents a sea change in how we handle thyroid nodules. And America is kind of late to the party on this, having only been approved a few years back. But the point is that this procedure can shrink nodules down while preserving that normal thyroid function. And why do we care about that? Thyroid, that's your thermostat. If it's not working, then nothing really is working. And we want to have the freedom to keep that intact as long as possible. So let's go back to some basics about thyroid nodules. They are super, super common. And what I like to say in new patient visit is that if I was out wandering around and giving ultrasounds to people on the street, let's say I did 1,000 ultrasounds, I'm probably going to find 600 nodules, okay? 95% of the time, these things are benign. And in the cases that are not benign, they are overwhelmingly a type of thyroid nodule, or beg pardon, a thyroid cancer that is naturally very indolent, very slow growing. So thyroid ultrasound is our best way to look at the thyroid, characterize nodules, understand what their risk is. Some nodules are hyperactive. They make extra hormone that they shouldn't be making, and they are ignoring the cues to stop doing that. And that represents about 5% of all thyroid nodules. If a nodule gets big enough, it can squish other structures around it. It can squish the laryngeal nerve, the esophagus, even the trachea, kind of pushing it off to the side. And that causes symptoms of compression, difficulty swallowing, changes to the voice, that kind of thing. So hoarseness, dysphagia. In some cases, I've seen difficulty breathing, the wheezing, that the air can't even get through the airway. So in this picture here on the top, this is just a general example of a thyroid ultrasound. If you think about cutting someone through the neck like a guillotine slice, and then you're looking up the neck toward the head, that is what this picture is here. Right in the middle, we have our windpipe. This structure that looks like a pair of saddlebags, that's our thyroid, nice normal echo texture. Here's our neck muscles up here, carotid arteries down here. And so you can see in the lower picture that we have a disruption of our saddlebag over on the right side of the picture. That is a jumbo thyroid nodule right there. And you can tell that it has a totally different presentation than the normal thyroid tissue around it. It's darker, it's patchier. And so that's what we're looking for on these ultrasounds. Now, as we said, they're very common, and we estimate that about half the population is going to have at least one thyroid nodule by the time they hit the age of 60. And the very, very small portion of them can be felt. The rest we rely on seeing on scans. And it's very common that they're found really by accident when someone lands in the ER for some reason, and we do a CAT scan of all kinds of things, and there you go, we found a thyroid nodule. So I want to orient you to how radiofrequency ablation works. This real simple diagram here. It's not so different than a thyroid biopsy, except instead of taking pieces of tissue out with the biopsy, that needle is applying energy to the thyroid nodule. It's minimally invasive. There's no incision. Nobody has to have general anesthesia for any of this. The nodule, or beg pardon, the needle is about the size of a large injection needle, like we would do for a muscle injection. And the energy that it applies causes heat, and then the cells in that nodule will slowly kind of die off and be reabsorbed by the body. So the nodule will shrink gradually over time. An ideal nodule for this procedure is going to be 2 to 3.5 centimeters. When we start seeing nodules that are bigger than that, we may end up needing to do the procedure twice in order to cover everything. Let's look at a timeline of the history of radiofrequency ablation. Korea was the leader of the pack here. They've been doing this for 2 decades, but it's been performed in many countries around the world over the course of the years. In 2016, the American Academy of Clinical Endocrinologists began making recommendations for thyroid ablation for nodules. The FDA gave its stamp of approval on radiofrequency ablation in the United States back in 2018. And then by 2023, the American Thyroid Association began making recommendations for radiofrequency ablation as well. It's now offered at many major medical centers, a lot of the big places, Mayo Clinic, USC, UT Southwestern, they all are doing this procedure. Insurance coverage can be spotty, but it is improving over time. And let's talk about who's a good candidate for a procedure like this. So obviously, we want you to have a benign thyroid nodule, and that proven by at least one biopsy. You can have this done if you have one of those overactive thyroid nodules, and that is designed to either reduce or eliminate the need for medication to control the nodules overactivity, and avoid that need for either surgery or radioactive iodine therapy. You can have this if your nodule is large enough to cause those obstructive symptoms that we discussed, hoarse voice or swallowing, or even if you can see it and you hate how it looks cosmetically. Who should not have RFA? At the moment, the recommendations are to not treat thyroid cancers or lymphomas, but there's data being gathered about its use in thyroid cancer. Nodules that impair breathing, such that they're kind of squishing the windpipe, because there can be swelling after this procedure that of course can make that compression on the windpipe worse. And what of course we don't want to do is cause you to stop breathing. Nodules that we call indeterminate, that we're not quite sure how risky they are, that need to have genetic testing on them done first to determine if they're a good candidate for ablation. Anybody with a pacemaker, we don't want to be using any kind of a device that will be applying any current to someone who has a pacemaker. People who are currently pregnant should not do RFA. And somebody who has a lot of anxiety about medical procedures, such that they're just kind of not able to lie still in order to do the procedure reliably. Or if you have a condition that prevents you from being able to extend the neck, because we really want to be able to position the neck in an extended position so that that nodule is brought as much to the front as we possibly can. That makes for a more complete and easier ablation. And certainly if someone is having bleeding problems, maybe they're on anticoagulant medications that they're unable to safely stop, it's probably not a good idea that we go doing RFA for these folks. And the big question, of course, is, does it work? And in short, yes, it does. It just takes a little bit of time here. In 1 month, we can expect reduction in volume by about half. At 3 months, we're expecting about 80% reduction in volume, and it will continue to get down even more for a total of 6 months. What we found in studies over time is that this reduction in size is stable and there's a good long-term effect. As we mentioned, we're gathering data right now about whether it's a good move to be treating certain types of thyroid cancer with RFA. And what I want to do is show you a brief video that we put together about how the procedure goes so that you can be familiar with kind of the sights and sounds.
Dr. Van Dyke here. We just got done doing a radiofrequency ablation of a thyroid nodule for a patient who was having obstruction. She couldn't swallow very well. And what I'm going to show you is how RFA works to shrink nodules 50 to 80% of their original size. Look at this. You can see the nodule here, and that line is the probe. All of the white stuff you see moving, that's the probe destroying the nodule on the inside out. We basically set up a surgical suite for this procedure. Probe. Probe on. Off. Do you feel anything, any sharp? No. Probe on. Off. I think we're about done.
Okay. So
Dr. Van
pretty
Dyke.
simple. So when we're getting somebody ready for this procedure, we have our initial visit because we have to know for sure, is RFA going to be a good choice for the patient? Is it safe? Is it appropriate? And to kind of get them ready for it. So if biopsies need to be done, we have to arrange for those. We have a fully informed discussion. And if we're a go for the procedure, we'll do all of our consenting at that time. We give the patient the instructions they need for that day, like don't have a heavy meal before you come in, make sure that you have someone to drive you home, make sure that you're wearing kind of gym shorts and a tank top for this because we have to put some pads on the legs. When they come for the procedure, most people opt to have a low dose of Xanax, and we let that sit for about 15 to 30 minutes and make sure they feel nice and calm. It just helps someone to be still on the table because you end up being on that table and in position for quite a while. We do all of the positioning and the setup, which arguably takes longer than the procedure itself. We give the local anesthesia to really get a good block on that entire thyroid. So the only thing the patient's going to be feeling is a sensation of pressure while we're working. The ablation itself can take up to 30 minutes. And then after we're done, by the time we get them up, get them back in their street clothes, do some observation, give instructions and discharge. It's about another up to 30 minutes at that point. So door to door, we're talking, 2 hours or so. Here's another example of how it works. Again, there's no surgical scar here. This patient gets to retain their normal thyroid function. They obviously had a beautiful reduction in total volume of that thyroid nodule. We're aiming for 80%. I want to make a point here that we're not aiming for 100%. It's part of the strategy that we leave a tiny ring of nodule tissue on the periphery because we never want that probe to break through the nodule. If that happens, patient ends up with sometimes some bleeding, certainly bruising, certainly pain, and it doesn't help the long-term outcome. So we leave that little ring on purpose. This patient obviously had very improved cosmetic appearance and then had improved symptoms with swallowing and voice. So, what's the risk? Overall, the complication for this procedure is somewhere between 1 and 2%. And if we compare that to complications from thyroidectomies across the board, it's significantly better. There, of course, is potential for bleeding, for infection, for hoarseness, because we're working under the skin. We're working in delicate areas. There are nerves that cross in there, and we have to take important steps to stay away from those structures that we don't want to cause harm. Most patients will report that they experience some pain when their lidocaine wears off, but they're easily able to control this with Tylenol and ice packs. There is, of course, as we mentioned, the possibility of difficulty breathing because when you do any procedure, you're going to cause some swelling. And so patients are always given precautions for an emergency room trip if they're finding that they cannot breathe. Okay? What does it cost? Well, what we know from multiple institutions is that it costs significantly less than surgery. The cost of the procedure individually depends on how many nodules there are, how big they are. Can we get it all in one go, or do we have to go through multiple procedures to get it? Like we said, nodules larger than 4 centimeters are pretty much always going to require more than one treatment. Nodules that have lots of blood supply, lots of vessels that all need to be ablated, may also require additional treatments to cut off all that blood flow. If we do not cut off the blood flow, the risk of regrowth is there. And the other thing is, of course, we can only treat one nodule at a time. And again, that's because of the risk of swelling or other complications. We don't want to cause any problems. So parting words here. I was the first endocrinologist in this Metroplex to begin RFA procedures. We've been doing it since 2021. Our motto, like Jen's, is save the thyroid whenever possible. In our experience, our patients thrive when they are able to have enough time with their doctor to have a thorough understanding of what's going on, have access to all the support and resources that they need, and are empowered to understand their conditions and modify approaches when needed. So if you think that this is interesting, we've answered your questions, we invite you to work with us to solve this problem of thyroid nodules. Very common, no longer requiring surgery for even the big nodules. If you think this is useful, please tell your friends about us. This video will be posted on our YouTube channel for reference, and you can find us on our socials, of course, at Dr. Van Dyke DO, Insta, YouTube, Facebook, and even LinkedIn. We were voted 2024 top doctors by Fort Worth Magazine, and I want to introduce you to the gals in the photo with me. On the left there is Miss Jackie. If you're calling, you have questions, any kind of insurance related things, she's the boss of everything. She knows the answers. And there's Nurse Pam in the middle. She is my lifestyle coach, my best damn diabetes nurse I've ever known in my career. And so the three of us are Advanced Institute for diabetes and endocrinology. With that, I'll invite you to ask any questions in the chat. We have our first question. Can the procedure be done on parathyroid nodules as well? The short answer is yes. I'm not sure if it has made it to guidelines yet. The last conference I attended, which was probably a year or so ago, there was more and more talk about RFA for parathyroids. Jen, I don't know if you have anything you want to add to this, if you've heard any updates there.
Okay, starting to unmute. Sorry. I am not super up to date on parathyroid RFAs. I know that they've been done. I know that it is it has been studied on intrathyroidal parathyroid glands also, where the parathyroid is inside of the thyroid gland. And I believe that is understood to maybe be safer if there's thyroid tissue around it because it's not in the neck exposed. But I think that it's growing in prominence. It's just like you said, there's not really guidelines on it yet. So stay tuned for that, I suppose.
I agree. Yeah, I think it's a natural progression that this will be applied to hyperparathyroidism.
I agree.
Are there any other questions that we could answer for you? Okay, well, I will not take up more of your day. I know you're busy, so I will make sure this gets posted to our YouTube and is available for reference. And I'm planning on doing a session like this probably every month because I think that there's a lot of interest and also a lot of people are not necessarily aware that this is even an option for them. So I certainly want to promote that this is rapidly becoming part of the standard of care. All right, everybody, thank you for your attention. Thank you for joining. It was a pleasure to talk with you, and I hope to see you soon.